A very common technique that people now know a lot about is mirror therapy. In this case, mirror therapy, we need to remember, is one of the final phases of graded motor imagery. We're going to use a mirror to trick the brain. It seems kind of simple, but the brain actually very easily can be tricked by using a mirror. In this position, we have the patient sit straight head on the table, not at an angle, otherwise the arm will be distorted. The instruction is that the hand in the box does not move. Now, the patient can move their hand. We just tell them, don't worry about the hand in the box. Clinically, you'll often see that hand begins to move a little bit. We want the patient to place her hand on the side here and then lean slightly over and look at her right hand being reflected into the left side. Remember, for a patient with a hand that is CRPS, very purple, swollen, or there's been scars from surgeries, just looking at the hand alone can be very, very overwhelming and provocative. So this, once again, has to be exposure. In this case, this is the first time Heather would have seen a normal hand. It's not swollen, it's not purple, there is no scar. So I will have her look across, look at her hand in the reflection in the mirror, look at it 2 or 3 seconds, nice deep breaths, and then sit back and deal with the image she just saw. By the way, she can do it again and again and again as she exposes. The next thing we want to do is take the hand outside the box, and Heather, all I want you to do is just look into the reflection for me one more time and just simply turn your hand for me out and back again. As she looks at this, her brain thinks the left hand is moving, although it's not. The nice thing here is she's running the map of pronation and supination, but there is no pain associated with it. So again, the map will unwire itself, unwind itself. Please remember, this is exposure. We cannot just go full blast into the box for 20 minutes. We do a couple of seconds, sit back, deep breath, deal with it, repeat, repeat, repeat. Watch carefully for the patient's emotion. If they move the hand in the box, not a problem, but that is not the primary focus of this technique. We can also then ask Heather to take her right hand, touch the mirror as if she will touch the other hand as she reaches across. Maybe one finger at a time, touching across, coming again, touching another finger. So she gets the sensation of moving, but also getting exposure of touch. Another technique we often may do is the introduction of the clinician's hand. Have the patient look at the reflection in the mirror, and then I come along as a therapist and I would touch. Remember, for people with significant allodynia, this may be very provocative. We can progress to things like techniques where she may hold a phone, she may be holding a screwdriver. We can build in towards functional tasks. Graded exposure, slowly getting the patient accustomed to this. But this is one of the latter stages of graded motor imagery. She has to know what left and right is, otherwise this will confuse the brain. During any of this, if the patient becomes emotional, the patient gets overwhelmed with this, we back up and then we maybe come back a little bit later and work on this a little bit further. As you've seen in the hand therapy one with the mirror box, we can also do it with feet. Simple mirror between the feet, guess what? In these two pictures, what the patient will see by leaning down and looking at the mirror, they will see a left foot. Well, guess what? The left foot could potentially be in a cast, could be in a brace. In the one picture, you'll notice I pull the mirror slightly back just to expose the shoe. But if you look at the other picture, you don't even see a shoe. And that's my point. It looks real. You mean that's my foot? It looks great. If you have a foot that's in a cast or a brace that's very painful to move, or it's purple and swollen, and now we replace it with the other image, the threat level goes down. How amazing, what a cool idea to take people with foot pain, ankle sprains, surgeries, for example, with a simple mirror to go home and do some exercise. For knee pain, it's almost just as simple. All of us can go to the local grocery store or hardware store or any store and buy one of these long, narrow mirrors that people often will put in the back of their closet, etc. They don't cost much. We buy a bunch of them in our clinic. If you place them between the legs, what happens? You look across and you see the other leg. This is being used a lot with soldiers, for example, with amputations, where they now suddenly see, hey, there's my right leg, although there's no right leg. We've had a lot of success with this with ACLs, with arthroscopies, people developing CRPS, following scopes, etc. But you can always put a mirror between those. The mirror one with the shoulder, I already showed you. We have these long stand-up mirrors you can buy. A lot of clinics have them. The involved arm, the affected arm, goes behind the mirror. The other one will move, and we look across, and it look as if this one is moving. How amazing. A simple mirror can do this. Now, as I'm talking about mirrors, I want you to know the new frontier is virtual reality. As I'm standing here doing this recording, I want you to know we are doing experiments, research with virtual reality, where we can actually do a lot of this visual stuff via a VR environment, and that will definitely be coming. But again, think about VR guys. For knee pain, it's almost just as simple. All of us can go to the local grocery store or hardware store or any store and buy one of these long, narrow mirrors that people often will put in the back of their closet, etc. They don't cost much. We buy a bunch of them in our clinic. If you